Pamidronate is a biphosphonate that binds to bone and inhibits osteoclast-mediated calcium reabsorption. It pulls calcium from the bloodstream and places it into the bone. Pharmacodynamics. Pamidronate's onset of action is 24 to 48 hours. It reaches maximum effect in 5 to 7 days, and the half-life depends on bone or blood.
Pamidronate's pharmacokinetics include poor absorption from the GI tract, and its metabolism is unknown.
Pamidronate may increase levels and the effects of phosphate supplements. The levels and effects of pamidronate may be increased by aminoglycosides, NSAIDs, and thalidomide. Side effects of pamidronate include tachycardia, hypertension, fever, fatigue, seizures, rash, nausea, vomiting, constipation, anemia, bone pain, myalgia, osteonecrosis of the jaw, conjunctivitis, renal failure, and respiratory symptoms. Pamidronate should not be used in pregnancy and is a pregnancy category D. It is probably safe for use in lactation and safe for treatment in bone metastasis unless the patient has severe renal impairment. It is contraindicated in hypersensitivity to any component in patients with severe renal impairment. There is limited research for the use of pamidronate in pediatric patients. Pamidronate is recommended for osteopenia in non-ambulatory children with CP. The recommended dose is 1 mg per kilogram per day for 3 days at 3-month intervals. There is no set renal dosage adjustment. Lactulose is a colonic acidifier which causes osmotic laxative effects and is used in the treatment of chronic constipation. It enhances the diffusion of ammonia from the blood into the gut, where it is converted to ammonium ions. It produces an osmotic effect in the colon, which increases stool water content, promoting peristalsis to produce movement of bowel contents. The half-life of lactulose is unknown, and its effects may not be evident until 24 to 48 hours after administration. There is less than 3% bioavailability when given orally. Lactulose is poorly absorbed in the GI tract and reaches the colon relatively unchanged. Absorbed lactulose is not metabolized. Unabsorbed lactulose reaches the colon and is converted into lactic acid and acetic acid by colon flora. It is eliminated 100% unchanged in the feces. Less than 3% is eliminated in the urine. When given with oral sodium phosphate, lactulose may increase the risk of dehydration and electrolyte abnormalities. Common side effects of lactulose include flatulence, abdominal pain, abdominal cramping, abdominal distension, diarrhea, nausea, and vomiting. Lactulose is pregnancy category B. Its safety in lactation is unknown. The safety and effectiveness has not been established in pediatric patients, and it is contraindicated in patients with a hypersensitivity to lactulose, patients with galactosemia, and patients requiring a low galactose diet. Caution is advised when giving lactulose to patients with diabetes, patients undergoing electrocautery procedures, and electrolytes should be monitored in elderly or debilitated patients if lactulose is to be used for more than 6 months. Miralax is an over-the-counter osmotic laxative used to treat occasional constipation. Miralax causes water retention in the stool, producing a laxative effect and increasing stool frequency. It is used as part of a bowel regimen to improve bowel function and promote regular stooling in the patient with occasional or chronic constipation. The half-life is unknown in this over-the-counter medication. Pharmacokinetics. There is a 0.2% bioavailability when Miralax is given orally. It stays in the colon relatively unchanged and is not metabolized by the CYP450 isoenzyme pathway. It is eliminated primarily through the feces and a little bit in the urine. Miralax interacts with oral sodium phosphate. It may increase the risk of dehydration and electrolyte abnormalities. It also interacts with activated charcoal and may decrease absorption of the activated charcoal and reduce its efficacy. There is no known interaction with KL's current medications. Common side effects of Miralax include nausea, abdominal bloating and cramping, flatulence, diarrhea, and hives. Miralax is a pregnancy category C and probably safe for use in lactation. Caution is advised when giving Miralax to elderly patients and those with renal dysfunction. Patient monitoring. Patient monitoring. For patients on clobazam, you should monitor for signs and symptoms of depression, suicidal ideations, and behavior changes. Abrupt cessation should be avoided. CBC, LFTs, renal function, and periodic thyroid function should be monitored.
You should avoid abrupt withdrawal of phenobarbital due to increased risk of seizures and status epilepticus. The therapeutic drug level is 10 to 40, toxic at 40 to 50, and you want to monitor CNS status, LFTs, CBCs, and renal function.
Clonazepam. Monitor the patient for signs and symptoms of suicidality. The therapeutic drug level is 20 to 80, and levels become toxic after 80. You should avoid alcohol and caffeine while taking this medication, and patients should have periodic CBCs and LFTs. Keppra. The patient's creatinine should be monitored at baseline before starting Keppra. Monitor for signs and symptoms of depression, behavior changes, or suicidal ideations. A serum Keppra level should be obtained along with CBC and renal function. For patients taking Ativan, a CBC and LFT should be obtained if the patient is on long-term therapy. Morphine. Monitor the patient for sedation and respiratory rate. Ensure adequate renal function. There is no recommended lab monitoring needed for patients on morphine, but the potential for abuse is evident, so monitor for abuse. Methadone. An ECG should be performed before and during methadone treatment to monitor for QT interval changes. You should also monitor for the abuse potential and avoid abrupt cessation of this medication.
Baclofen. Monitor spasticity, muscle rigidity, and Ashworth score. Creatinine should be obtained to see what the baseline level is, and you want to monitor an EEG if the patient has a history of epilepsy. Calcium carbonate. Monitor calcium levels, monitor the creatinine clearance, and monitor dietary sources of calcium.
Pamidronate. Monitor hydration status and urinary output. Monitor for renal impairment. Monitor serum creatinine before each dose, and monitor the calcium, phosphate, potassium, and magnesium. Monitor a CBC if the patient has a history of anemia.
Lactulose. Monitor fluid status and electrolyte balance, stool output, and ammonia levels. Miralax. Monitor serum electrolytes, monitor stool output, including frequency and consistency. Monitor bowel sounds. Should not be given to a patient with a suspected obstruction. Patient education. KL is unable to care for herself due to a neurologically devastating event at 3 months of age. KL is cared for by trained staff at the long-term care facility. Verbal and written education was provided to the staff regarding seizure precautions and vital sign monitoring. It was stressed that the importance of on-time drug administration and to not skip any doses of medication. You want to adjust the G-tube feeds accordingly to ensure that there are no drug interactions with his formula. Lab monitoring and appropriate collection times should be done for adequate drug level measurement. Encourage the staff to keep a seizure log, assess pain using the FLAC scale, and monitor heart rate and blood pressure as they are objective indicators of pain. Keep the multidisciplinary care team up to date and the family of the patient status. Pharmacology-related problems.
One of the patient's medications, pamidronate, is nephrotoxic. His current dose is 40 milligrams, which is 10 milligrams over the recommended dose for someone his size. We recommended decreasing the pamidronate dose by 10 milligrams to continue to provide therapeutic effect while also taking into consideration the patient's current palliative orders. Along with the risk for nephrotoxicity, there is limited research regarding the safe and effective use of pamidronate in the pediatric population, and it is not labeled for use in pediatric patients. Pamidronate is actually indicated for use in hypercalcemia of malignancy. It is not approved by the FDA for the treatment of osteoporosis. The patient is also on multiple medications that put him at risk for polypharmacy-associated drug interactions. According to Hippocrates, there are over 20 interactions between his current medications. The most severe of these include an increased risk for CNS depression and psychomotor instability. Drug interactions. Onfi and clonazepam are 3A4 substrates, while phenobarbital is a 3A4 inhibitor. Long-term use of phenobarbital may increase the daily requirements of vitamins D, K, C, B12, and folate and calcium. This could be, in part, contributing to the patient's increased risk for osteoporosis. Because of this patient's past medical history and poor seizure control, discontinuing Onfi, clonazepam, or phenobarbital is not a realistic option. His quality of life needs to be enhanced as much as possible, which means keeping him pain and seizure free. So his medications really cannot be adjusted, even though they place a potential for polypharmacy interaction. Conclusion. The patient did not need any refills on his current medications at his appointment. No new medications were prescribed at his visit, and he did not need any other dose adjustments other than lowering his pomidronate dose.